Good evening. This evening, we're just going to talk about steatotic liver disease, also known as MASH, MASLD, formerly known as NASH and MASLD. We're going to talk a little bit about the name change, and just wanted to say this is a great opportunity to talk about this tonight because next Thursday, June 12th, is actually Global Fatty Liver Day. So, formerly the non-alcoholic fatty liver disease has now been changed to a larger name called steatotic liver disease, which encompasses many different avenues of fatty liver. The most common one, and the one we're going to really focus on tonight, is metabolic dysfunction-associated steatotic liver disease, which is also known as MASLD. And then it can, as it advances, become MASH, which is metabolic dysfunction-associated steatotic hepatitis. This is just one category of what falls under the big window of steatotic liver disease. There's also MASLD, which combines the metabolic functions and alcohol use that cause the fatty liver. There is straightforward alcohol-associated liver disease, and then there are different etiologies that can cause fatty liver, things like drug-induced liver injury, different diseases, different medications, and then cryptogenic issues as well. Whoops. Uh-oh, I don't know how to go backwards. Okay.
You can, at the bottom. Yeah, at the bottom, you could maybe see, like, click out of where you are. And then on the left side, there might be, you could also use your right and left key.
That's what, I think I was using the wrong side of my clicker.
Okay.
Yep. Okay. I wonder if I can make that. I wish I could make it bigger. Okay. So steatotic liver disease is usually identified either by elevated transaminases, various liver function tests, or by imaging such as an ultrasound, or eventually by biopsy. So when you want to decide if your patient might have metabolic dysfunction-associated fatty liver or steatotic liver disease, you want to see if they have any of the metabolic criteria that can define this disease state. So for an adult, they need to have at least one of the following criteria: a BMI greater than 25. It can be lower in Asia, 23, or it can be a waist circumference of greater than 94 centimeters in males or 80 centimeters in females, or they can have an elevated serum glucose, or known type 2 diabetes with medication, elevated blood pressure or on treatment for blood pressure, elevated triglycerides greater than 150 or on medication. And I think there's something on your screen. Whoops, sorry about that. I keep doing this. This is going to be awful. I'm sorry. Or HDL lower than 60 or lower than 50 in a female, or lower than 40 in a male. I apologize for that. So then once you just see that they have the criteria, you want to decide if there were other causes of steatosis, such as medications, things like amiodarone, methotrexate can cause, but if there is no other cause, then you can go ahead and say that they have metabolic dysfunction associated steatotic liver disease. If they have advanced alcohol use, then they could have the overlap. And then you always want to look for other etiologies. So other than just testing for your metabolic issues, you want to look for things that can cause other things that could cause elevations in your transaminases or your liver function. So you want to check for autoimmune issues. You want to check for viral issues. You want to check for hereditary issues such as hemochromatosis, alpha-1. Slides to move.
What's wrong? Just not doing a good job. I could also advance them for you.
Thank you. Can you advance the next slide? Thank you.
Yeah.
I don't know why I'm having so much trouble with this.
It's okay. And like we could always we have an editing team and like every time we talk they could edit it out. So you're totally fine.
Thank you. Okay. So we've just basically, as far as your practice, the term MASLD replaces NAFLD and MASH replaces NASH. Studies have shown that there is a 99% overlap between the metabolic dysfunction associated steatotic liver disease and the historical non-alcoholic fatty liver disease populations. The terminology was changed just because of the bad reputation. You use the word alcoholic and people didn't understand that we were saying they weren't drinking. So all of the recommendations presented by the AASLD practice guidelines on NAFLD can be applied to patients with MASLD and MASH. And results from natural history and biomarker validation studies among patients with NAFLD and NASH are applicable to the patients with MASLD and MASH. Okay. So in order to define, once again, you want to look for their cardiometabolic risk factors. They need to have at least one of the 5. We talked about BMI greater than 25, 23 in Asians, and there can be slight differences for other ethnicities. Waist circumference greater than 37 inches for a male, 31.5 inches for a female, fasting glucose greater than 100, or an A1C greater than or equal to 5.7, or known type 2 diabetes, blood pressure greater than 130/80, or on treatment for high blood pressure, triglycerides greater than 150 or on a lipid-lowering agent, and HDL less than 40 in males, less than 50 in females, or on a lipid-lowering agent. This excludes patients with excessive alcohol consumption greater than 30 grams per day in a man and 20 grams per day in a female. So if you suspect that they have fatty liver disease or steatotic liver disease, the first thing you want to do is your basic labs. So a lot of labs these days will automatically calculate your FIB4 if you have a CBC and a hepatic panel, including the AST and ALT. And so if your FIB4 is greater than or equal to 1.3, then you want to look further at your patient to make sure they don't have advanced fibrosis and that they're high risk for developing further complications. If they do not have an elevated FIB4, you can reassess in every 1 to 2 years. If they have diabetes or if they have greater than 2 metabolic factors. If they do not have diabetes and they have less than 2 metabolic factors, you can reassess in 3 years. If they do have a FIB4 that's greater than or equal to 1.3, then you want to go ahead and try to get a FibroScan or an ELF test. These are 2 other non-invasive testing methods that can help you with your risk level of your patient. With the FibroScan, if their VCTE, or that's their elastography, is less than 8.0, or their ELF score is less than 7.7, this indicates that they're at low risk for having advanced fibrosis. If their elastography result is between 8.1 and 12, they are at intermediate risk. If their elastography is greater than 12, they're at high risk for having elevated fibrosis levels. And if their ELF is between 7.8 and 9.8, then they're at intermediate risk. If it's greater than 9.8, then they're at high risk. The nice thing is too, also with your FibroScan elastography, there are some additional tests that can be calculated based on your CAP score and your KPA or your elastography score that can help you to determine the level of risk of your patient. Next. Okay, so in hepatology, our goal is to make sure that we get these people that are at risk for developing MASH or advanced fibrosis. And we do know that if their FIB4 is greater than 2.67, or if their liver enzymes, basically their transaminases, remain elevated over time, regardless of changes in diet, weight loss, then we know that they're at higher risk, and this is when you want to make sure they're getting to hepatology or GI for additional evaluation. Okay. Once they're in specialty care with suspected advanced fibrosis, we're going to do a secondary risk assessment, and we're going to consider a liver biopsy if their non-invasive tests are not clear and they don't really help us delineate what's going on. Again, if the enzymes are staying elevated and you're not really sure what's going on, you want to make sure that we're not missing something. So there are different stages of fibrosis. Stages 0 to 1 are your low risk, 2 to 3 are your intermediate risk, and stage 4 is cirrhosis. So if your non-invasive tests and your biopsy indicate that they're at stage 0 to 1, you can reassess every 2 to 3 years. If they're stage 2 to 3, we can reassess annually. And in the last year, we now have a pharmacotherapy that we can use for these individuals. And if they're stage 4, you want to start cirrhosis-based management. That's, you want to do things, preventive care. You want to evaluate, make sure they're not developing liver cancer or liver failure. And if their ELF test is greater than 11.3, or they're showing clinical signs like thrombocytopenia, then you want to go ahead and presume that they have cirrhosis. This is not just limited to the United States. Throughout the world, there are different areas that have different levels of fatty liver, and it's very unfortunate that it is increasing over time. Latin America has the highest incidence, but as you can see, pretty much everywhere around the world is over 20% of their population having fatty liver disease. Okay. We know that in the United States, 60 to 80 million Americans have been affected with MASLD, and of those, 15 to 20% or 15 to 20 million will progress to MASH. Over 3 years, 20 to 30% will continue to increase their fibrosis to stage 1 to 3, and they can develop hepatocellular carcinoma. Most people will progress their MASH stage 1 stage per every 7 years, with 20% of patients being fast progressors, and they will go to cirrhosis within 10 years. So once they have fibrosis, they can progress to stage 3, then 1 to 2 million of those will progress to cirrhosis, possible liver failure, and be at risk for needing a liver transplant. 30% of patients with cirrhosis will die from liver disease. However, patients with metabolic dysfunction-associated steatotic liver disease, the primary is still cardiovascular. Okay, so this graphic just shows us the progression of MASLD. So it starts with a normal liver, and then you see where the fat accumulation begins. There are genes that have been discovered that tend to put you at higher risk for progression to at-risk MASH and cirrhosis and development of liver cancer. There are also a few genes that have been shown to be protective. When you're F1 to 3, we still consider you reversible, but once you progress to cirrhosis, at this point, it's still not considered reversible. There are studies ongoing to look at this, and we're hopeful that we will find some good therapies to help people be able to reverse. But when you are cirrhotic, you have an increased risk for the development of hepatocellular cancer. AASLD has provided new guidance in 2023, and they have said that if you have MASH and F2 to 4 fibrosis, you're considered at higher risk for liver-related events. They now call this at-risk MASH. Rates of fibrosis progression and hepatic decompensation depend on the baseline disease severity, genetic, individual, environmental, and comorbid disease determinants. Cardiovascular disease and non-hepatic malignancies are still the most common causes of mortality in patients with MASLD without advanced fibrosis. Death from liver disease predominates in patients with advanced fibrosis. So now we're going to do a patient study. Our patient is JP. He's 55 years old. He's a white male with obesity, BMI of 35. He was referred to us for elevated aminotransferase. I can never say this right. Transaminases. He has right upper quadrant discomfort. He's gained 20 pounds over the last 5 years. He has mostly normal liver chemistries over the previous 5 years with mild intermittent elevations, ALT of 45, AST of 50, normal ALP, and total bili. Now, in the hepatology world, we consider anything over 30 in an ALT, AST is abnormal. He has a past medical history of obesity. He weighs 230 pounds. He's pre-diabetic. A1C is 6.3, and he's got hypertension. He has no known family history of liver disease. He rarely drinks alcohol, works in IT. He's on lisinopril for his hypertension. On exam, he does have central adiposity, and his waist circumference is 110 centimeters. So he's clicking those boxes for those metabolic risk factors. So we do know that there are medications and other disease states that can cause elevation in your transaminases as well as fatty liver. Medications such as amiodarone, methotrexate, certain cancer therapies, steroids, antiretrovirals that can all lead to development of steatosis in the liver. Hep C, Wilson's disease, hemochromatosis, malnutrition, celiac disease, post-Whipple, post-gastric bypass. A lot of these people can develop steatosis and also fibrosis. So when you evaluate your patient, we were talking about this earlier, you want to rule out other causes of liver issues. So you want to do viral hepatitis serologies, A, B, and C. You want to check ferritin levels, iron saturation, transferrin saturation. These are indicators for hemochromatosis, but they could be elevated if your patient is not honest about their alcohol intake. You want to check an antimicrobial antibody, celiac panel, anti-nuclear antibody, anti-smooth muscle antibody, alpha-1, and then your basic CBC, CMP, INR. You want to check for HIV, check lipids, A1C, thyroid function, and your PEF is a nice test for alcohol use because it looks at the past 3 weeks, not just the past 72 hours. On imaging, your ultrasound can detect steatosis. However, they have to very significant amount of steatosis for it to show up well on ultrasound. So if you look at the top image where the liver and the kidney are both marked, their brightness is about identical, but on the lower image, the liver is dark in comparison to the kidney. So that's echogenicity, which is an indicator of steatosis. So back to JP. His ultrasound did show increase in hepatic echogenicity with regions of focal sparing. The contour appears smooth, which is a nice finding. If it was nodular, we would suspect cirrhosis. Spleen is 9.5 by 9.4 by 3.5, which is not enlarged at this point in time. So the impression is hepatic steatosis with no evidence of portal hypertension. Now, curiously, we've got all these lovely non-invasive tests that are very specific and very helpful, but who might still need a biopsy? So if your non-invasive testing is still indeterminate, or if your labs and your test results don't line up and they're discordant, you might want to do a biopsy to determine if they're F2 versus F3. If they're older, you may want to do a biopsy because some of the testing is age limited, FIB4. If you're over 70, the results are not as accurate. Also, you might want to look at other tests for things like iron overload, which is common in hemochromatosis, autoimmune hepatitis, which is difficult to diagnose without a biopsy, and effects of medications or other bacterial issues, cancer, things like that. Okay, so back to JP. He has hepatic steatosis identified on his imaging. He does exhibit metabolic criteria. We didn't see any other causes of steatosis. So he's got the elevated BMI. He's got the elevated fasting serum glucose. He's got elevated blood pressure. He's on medication for his blood pressure. So we know that he's checking off those boxes. And we can pretty much make the assumption that he's got metabolic dysfunction associated steatotic liver disease. Now, if we got his PEth test back and it was elevated, then we might be looking at the MASLD ALD overlap. So the things we want to know: does he have any underlying steatohepatitis? Does he have any fibrosis? And does he have advanced fibrosis? This is where additional non-invasive testing comes in handy. So this is where you would want to refer for something like a FibroScan, do an ELF test to help you determine how significant his fibrosis was. And this is where you might want to refer out if you had any questions. But if his FIB4 is less than 1.3, you just want to manage his metabolic factors to prevent any additional liver damage.